welcome Dr. Ben Talei today, who is, I admire his work, and he's in Beverly Hills, California. Dr. Talei was trained at UCLA as an undergrad and then went to medical school at UC San Diego, did head and neck surgery training at Columbia University. A fellowship in facial plastic surgery followed in New York City, and also did a second fellowship in vascular birthmarks in New York City as well. So he is widely published. I've read a number of his articles, and I've learned a lot from reading his articles and attending some of his lectures. I find him to be very honest and very straightforward and very enlightening about whatever subject he's speaking about. And he also participates on a biannual basis in medical missions for underprivileged people around the world. So today I'm very happy to speak with you. I noticed that your office is on Roxbury Drive. Is that correct?
Yes.
And it just so happens that I spent a year of my own training on Roxbury Drive with Dr. Norman Shore, who I was one of his first fellows at UCLA, and so it was only like yesterday, only 30 years ago, though.
He was extremely popular around here.
Yeah. So today we're going to talk about one of your favorite subjects, and one that you've given me, you've kind of woken me up to, which is lips. And my first question to you is, why do we lose volume in our lips? And I see many patients who are 50 to 90 who have lost, particularly women now, who've lost volume in their lips, and they don't know what can be done about it. Once I show them that they won't look like Goldie Hawn by injecting some filler in their lips, they have confidence in what I'm telling them, and they're very pleased that they now can apply makeup to their lips. But these are the middle-aged and older women, and I noticed that you take care of a lot of younger women as well.
Yes.
Who have really focused on lip aesthetics. So I'd like you to enlighten me about the types of patients you see, and what makes up a beautiful lip when you, from your eye, and how do you assess the patient to let them realize what their vision of a beautiful lip is?
Sure. So I do treat patients in a wide array of ages, I'd say. So I have the younger patients, typically under 20, they're for like cleft palates and lips and stuff like that, where I'm doing corrective work. But over 20, then I see them usually for either volumization or lip lifting. And then as they get into the older age bracket, definitely for volumization and lip lifting both. You see different things in all those age groups. Some people genetically are born with a thicker or longer lip, and then as they age, it can get even longer. And then the other issue that we see is overfilling in the young age group. And then as we get older and older, we see that the lip starts naturally losing volume and lengthening over time.
Well, why is that happening? I'm going to stop you right there,
Sure.
Dr. Talei. I want to understand what's happening in our face.
Okay.
Why are we getting this lengthening process? Is the whole face lengthening? Are we getting saggy? What's happening?
So lots of things are happening at once, but the tissue elasticity changes over time, and as you can see with the face and the lip, it doesn't really have as much resilience as people get older. They lose a little bit of fat in their face, but it's not just fat. The dermis itself weakens a little bit, and the SMAS layer, which is another fascial layer in the face and in the lip, tends to get a little bit thinner over time. The muscles in the face can get a little bit thinner too over time, so you get this overall volume loss.
What?
In addition, Mhm.
Okay, go ahead. I'm sorry to cut you off. Go ahead. In
Yeah,
addition,
in addition, just with loss of tone of the muscle and gravity over time and movement over time, you tend to get lengthening as well. So most people, their lip will lengthen over time, and as it does, you'll see that it tends to cover the teeth more, and as they smile progressively, they start to form a crease up where the lip kind of wants to start.
Mhm.
So this kind of naturally happens to almost everybody, just to varying extents depending on the density of their skin. Uh,
I want to interject here and just say that in my experience, I've seen a number of people who have smaller, thinner lips
mhm.
because they have gum recession, and there's a change in the structure. I think of the teeth as being a structural support for the lip,
Yes.
and as those changes occur in the mouth, inside the mouth,
hmm
it then is transmitted to the lip itself.
Yes, yes. With the attrition of the teeth, you do see that. And a lot of the dentists that we work with like to compare the show of the teeth or the position of the teeth on the lip. They compare it to a person standing behind a curtain. And if they're standing all the way behind the curtain, far back, the curtain hangs all the way down. As they start to come forward, the curtain starts to kind of lift up and forward, and you see the teeth or the person coming through behind the curtain. So you certainly do see that over time.
Mhm.
In the younger age group, the main reason we're seeing patients is to simply either add volume because they want sexier, more sensual lips. Whether or not they already have a full lip doesn't really matter to them. And a lot of them come to me specifically to get lip shortening, meaning the lip itself, they feel it's too long. And that can be either because the overall volume is too much, meaning some people have a thicker upper lip and it's just too much mass. So they want to decrease the mass of the upper lip, or they want to decrease the height of the upper lip in order to get more tooth show, more pout, and more vermilion show. The vermilion being the pink part of the lip sometimes on patients is buried, and the vector, if you look at it from the side, points either forward or straight, as opposed to the kind of sexier or
Pout.
sexier accepted lips, which pout
Mm-hmm.
upwards, meaning they have
Mm-hmm.
some eversion. And
Mm-hmm.
in that case, that's when we're doing the procedure called an upper lip lift. And there's 1,000 different ways to do that.
Okay. Well, before we get into the details about your surgical procedure that you've written about in a very erudite way, can we define, for instance, the dimensions of the lip as being
Sure.
like, is it, I was always under the impression that people have, or women, this is in particular, and we're only talking about the upper lip now,
hmm
that there should be a smaller upper lip vertical height relative to the lower lip. The lip, the vertical height of the lower lip should be longer, like 1.5 millimeter or 1.5 versus 1 on
hmm
the upper lip. Can you
Yeah.
give me some? Do you abide by these ratios, or do you just
Um,
eyeball them and just kind of look at the patient as a whole?
yeah, I find eyeballing them serves me a little bit better. The ratios were great for me initially as a guideline to help understand the face, because you're going through years of training, and through that, nobody really teaches you how to assess a face, or who knows who's actually right when they tell you, what beauty is and what a beautiful face looks like. So uh, the guidelines of the ratios of the face, the golden ratios, the fifths and the thirds, they're all very helpful for looking at the face, analyzing it, assessing it, and trying to really understand what makes the face look nice, what makes this person look balanced, and their face look harmonious or sexy or young. So I did use those ratios initially, and then over time, as I became more experienced, and this is doing lots of surgery, lots of fillers, and just lots of listening, meaning I just listen to what patients say, whether or not I thought it was crazy sometimes or
Hmm.
um, valid. I would just listen, and over time, you start to understand really what people are looking for and where other doctors went wrong. And that's the main thing that really helped me, was seeing where other doctors went wrong, and that helped me really understand what the balance of the face should be, how to kind of preserve anatomic function in the face as you're going, through different types of options for surgery or fillers or things like that. So now when I look at a face, I look at it just overall, I eyeball it, and I just imagine to myself, okay, well, what if I were to shorten this part of the lip? What if I were to volumize this part of the lip? What would happen to the rest of the face around it? Would the nose look too wide? Would the chin look too long? And you start to see that there is no perfect measurement for the lip. There is no too long. There is a too short, because you kind of lose function at some point. But realistically, you're just trying to make it fit with whatever's surrounding, because you're not going to go change everything about that patient. They're coming in for one thing, maybe two things, and you want to just tweak to make the lip fit everything else around it. So somebody who comes in with a prominent chin and an underbite, you're not going to go make their lip short and not add volume to it, because it's going to look terrible. You're going to actually try to add volume, make it a little more prominent, try to balance it to everything else.
I understand. So you're aiming for harmony, facial harmony, but what you said was that you ask the patient, you involve the patient in the decision making. It isn't purely a one-sided decision. And I think you're right. I think that the surgeons or the plastic surgeons or the dermatologists, or whoever are injecting, they are imposing their own aesthetics, so to speak, on the patient, and they don't really listen carefully to what the patient wants. I think that's where they go wrong. I don't think it's necessarily technique as much as lack of communication.
Yeah, I agree, and it's a big part of being, to become a successful surgeon, to have a successful practice, happy patients, and you being happy. You really have to read people. You really have to read people, because if you don't, you're going to have a large subset of those patients either upset at you or kind of getting something they didn't ask for, or you'll do something on a patient that you shouldn't have because you didn't read them properly. So even with this kind of stuff, it does make a big difference to me now, or I see it more, where I would see like a young Russian girl and I would approach her very differently than an older African-American woman. Their desires are completely different. Their aesthetic is completely different. And to make them happy, you have to play with a different set of rules. All of them, of course, kind of staying within your set of rules, which is, okay, I'm not going to make anyone look fake. I'm not going to make anyone look done, operate, anything like that.
Yeah.
But I do treat those patients differently. Even in my lectures, I say, okay, well, you have 11 millimeters or so being the shortest. You're going to go for the height of the upper lip in this area, unless you're treating a Russian girl who's 25 years old and their aesthetic is different. You can actually go to 9.5, 10 millimeters. So,
well, that brings me to the next question, because as an oculoplastic surgeon, even 30 years ago, I said to my colleagues, my mentor, I said, we're doing things now that I don't know if it's going to look good in 20 years.
Right.
I actually had that thought in my mind, even when I was in training. And I'm wondering, are we all committing the same mistake again? Because what's popular now, just like how rhinoplasty, the nose jobs were done differently 30, 40 years ago, 20 years ago, are we doing things now that maybe people will regret later?
Yeah, so these are, it's a topic about trends of surgery and trends of aesthetics. And the way I've looked at it, I do always worry about longevity. I always do. And I have an aging face practice. So I'm seeing patients in their 60s and 70s who had multiple other procedures. And I always try to think about, okay, where did these other guys go wrong? Well, the conclusion I've come to is very simple. And it's really about understanding anatomy. When I do surgeries, any surgery I do, I keep the patient anatomically correct. Meaning, if I were to do a facelift on a patient and you were to go in as another surgeon and open up the face again, you would find everything exactly where it should be. Meaning there's going to be no surprises. You don't have to worry that it's a revision. You don't have to worry that it's a secondary. Everything is exactly where it should be. When things are placed like that, everybody will continue to look normal. They'll look natural. And they will age naturally, as opposed to, let's say, doing a biplanar facelift, where the face is all aged kind of in this direction over time, and all the tissues descended together, and then a surgeon will go in and pull one in this vector and one, another part of the layer of the skin in that vector. They're not going to age appropriately. They're going to age in a very strange fashion because redundancy was taken incorrectly in one vector and correctly in the other. They're going to age in a strange fashion. But if you leave things anatomically correct with no tension on them and everything is really sitting naturally and calm and nice, it would be an extremely low chance that they would ever age poorly or regret what they did, or they would, you'd fall into like a period of time where it would be trendy to have something else because you kept the
But
patient
Ben,
correctly.
what I have to cut you off here, Ben, because again, what I'm and I'm not putting you on the spot, but again, you're giving a young woman who's in her 20s or early 30s fuller lips, okay?
Yes.
And what I'm implying is that is popular right now. That is a popular look based on the Kardashians and other people, okay?
Yeah.
And what I'm saying is, we don't know, to be honest
That's
with you.
correct.
If you're honest with yourself, we do not know what is going to be the popular look 30 years from now. And so, even if it's anatomically correct, once you do surgery and once you alter that anatomy, I'm not saying you don't produce beautiful results, and I've seen those results in your papers that you've written. But all I'm saying is I'm bringing this up as a possibility that I want you, that I'm sure you think about, but I'm just saying that it is a possibility that we really can't solve sitting here talking about it, to be honest.
Oh, of course.
But
yeah, and I am constantly thinking about that because, again, I'm seeing the aging face population. I'm seeing kind of what surgeons have done over the past 20, 30 years. And every time I'm doing a procedure, I try to keep myself within those limits.
Okay.
But for sure, it's a consideration, and you don't know if the trends are going to change. So the alterations I make to somebody, you make to somebody, we try to make them as, I'd say, as natural as possible for them to fit their face. Whether it's, if we were to look at them 80 years ago or now, the same thing would hold true, that they still look good, they still look balanced and nice.
Okay.
But yeah, there's a lot of over volumization going on for sure.
Yeah. So
especially in LA.
Now I'm going to get back to the lip, even though we could talk for hours about other subjects. I'm sorry, I digressed. So now the patient comes in and she's in her 20s, and of course most people in the United States who do aesthetic work, whether they're facial plastic surgeons, dermatologists, oculoplastic surgeons, whoever they are, general plastics, most of them are augmenting the lip by injecting fillers.
Yes.
And so what really captured my imagination with your paper on the modified lip lift was to draw my attention to the possibilities of doing a more permanent procedure to augment the upper lip, and or let's say change the contours of the upper lip. But could you give us some pros and cons on lip fillers versus surgery, for instance?
Sure. So lip fillers, the main ones that we're using are hyaluronic acid fillers. So it's a sugar-based gel, let's say, that's kind of made from bacterial fermentation. And it seems to be the most benign in general of all the types of fillers. So we have Radiesse, which is hydroxyapatite crystals or bony crystals, should never be placed in the lip. There's Sculptura, which causes fibrosis or granulation, should never be placed in the lip. And then you have things like silicone and silicone-like polymers, which should never be placed in the lip. And then you have fat. And fat itself, although people would think it's natural, it's not really a natural thing to take fat from your abdomen and put it in your face. So it does carry its own set of risks. When we look at all these options, the most predictable of an unpredictable procedure, which is injecting, seems to be the hyaluronic acid fillers because they're reversible. It doesn't mean that they don't.
And they're off the shelf. They're easily accessible.
Exactly, and there's an extremely low reaction rate to them, and they're in general very benign. The fillers, we've been using them for either accenting the lip, volumizing the lip, or changing the appearance of wrinkles in the lip. So we can add volume into wrinkles up here, or we can just revolumize the lip itself or improve accent. It doesn't do much in terms of lifting the lip or anything like that, like people would think, but it does help with eversion and overall prominence. The problem that we see with the hyaluronic acid fillers is, well, no injectable is predictable, meaning you inject it in one spot, it can move to another. they're hydrophilic, so they do draw water in around them, and they can move by capillary action, so they can actually crawl into different spaces around them. The most, I'd say, notorious for this is Juvederm. That's the most popular that doctors use also. So it's probably the worst hyaluronic acid filler for the lip because it's the least predictable. It tends to move about a centimeter north, whereas if you use another product like Volbella, Volure, Restylane, the most they move is maybe like 1 or 2 millimeters. So these products can migrate, they can bring in volume around them, and they can chronically over time thicken the upper lip and diminish the function of the upper lip. Diminishing the tone of the muscle in the lip can actually elongate it. So patients who use this over time repeatedly and it's crawling into the wrong spaces, their lip gets longer and expansive over time.
And that's a very fascinating thing. Has that been proven by scientifically proven, or is that papers on that, or is that something you just observed? I'm very interested in that. Huh?
Yeah, so I've observed it surgically several thousand times, and meaning I can actually go see the filler that in the different areas of the lip, but you can visibly see it on people, and once you become cognizant of it, you start to see it on a lot of people. So it's very visible, very obvious, and I give lectures on this, on the fillers, and I always tell the audience, I say inevitably at the end of the lecture, somebody's going to come up to me, a doctor, is usually a woman, and they're going to say, well, I've been using Juvederm for years and I don't see a problem with it. Why would you say that? And I look at their lip, and their lip looks like a duck. Like they just have filler all the way up here and projected out. And it happens every single lecture, even though I say the same thing, and then they always come up to me at the end. And it's a matter of kind of being oblivious to things. And we don't
they can't see themselves in the mirror. Let's put it that way.
Right. And you don't see the issue unless someone has pointed it out to you and really drawn it out, saying, look, this is the problem we're seeing.
Yeah.
In Los Angeles, it's very common.
Yeah.
We see it a lot, and it's the whole Kylie Jenner thing. So, Kylie Jenner had filler all around here, all the way up. It thickened her lips. She had balls everywhere because they passed into the wet, dry vermilion. The wet vermilion where you shouldn't be filling. So it can be a problem for patients over time. However, when it's done delicately, carefully, and cautiously,
is it the amount of volume that people inject is the biggest problem, where you think it's the placement of the filler?
The biggest problem is the filler type.
Filler type.
That I've seen, and I deal with a lot of lips. So the biggest problem I've seen is just using Juvederm. People use Juvederm and they inject it properly. So they inject it right under the vermilion border, which is an appropriate place to put it. And then 2 years later, you see it's popped up here. And it'll last 10 years. It'll just stay there.
It lasts 10 years?
Yeah. So Juvederm, especially once it goes to the wrong spot, there's 2 wrong spots on the face for Juvederm. One is the under eye, one is the upper lip above the vermilion. They're 2 spots that are very reactive to Juvederm specifically. So once you get that water retention, it's very shelled off and protected from the body's metabolism. So it tends to stay there up to 10 years, which is also why patients are kind of misled, not realizing what's been going on, because they think to themselves, I don't have filler. And I asked them, I said, have you ever had filler? Well, no, I don't have filler. I go, yeah, but have you ever had filler? Yeah, but I had it 8 years ago. It's impossible. I go, well, it's not impossible because I'm staring at it. So it's there. How do you know it's there? Okay. I'm like, well, how do I know the sky is blue? I know the sky is blue. It's a immediate recognition. So I have that conversation a lot, and it takes 2 seconds to go change someone's life and return them back to normal. And the biggest thanks I get for doing this is from parents. So the parents immediately tell the kids, or they could be 30 years old, it doesn't matter, 40 years old, but their children, they say, oh my God, you look so much better. Oh my God, you look so much better, just because we dissolved this kind of monkey lip or mustache that they've had sitting there for years and they didn't know it was there. Right. And doctors who inject it, they only inject because they don't see it. If they saw it, they were aware of it, they wouldn't be injecting it. So the biggest problem I see is the filler type. The injection position or the placement is also a problem, where doctors don't understand what lifting is or what balance is, so or they try to keep someone from bruising, so they inject from above the lip, but then you're immediately getting backtracking of the filler into the wrong area. So placement is secondary. It's usually just the wrong filler type. And around LA or areas where our tastes are a little skewed, you do see over filling. So they just go for too much filler, and they're trying to get an appearance or an outcome that they shouldn't be getting. It just doesn't fit their face.
I got
filler
it.
is not always the solution. You can't just keep volumizing things. So they end up getting very ducky and, in my opinion, very
Extreme
gross
looking,
looking.
huh?
Yeah, yeah, and it's not sexy. It's not delicate. It's
Yeah.
not anything any guy would like, or any woman would like when they, when they look at somebody else.
Hmm.
But patients, they develop this sort of dysmorphia, and they are, it's propagated, unfortunately, by the most popular people on social media.
Yeah.
So, and social media now is, I'd say, more in our lives and pervasive than TV, as far as media goes.
Yeah. When especially young people. So, but there's a big leap, or let's say a psychological leap for young people to say, okay, I'm going to go to Dr. Talei for a lip lift.
Hmm.
That's a big decision on their part.
Oh
They're
yeah.
little, it's, I, I've seen the pictures of the post-operative care. First, before I get into that though, I want to backtrack for one more minute because there are other indications for doing the surgery, or let's say the decision to have the surgery, of course, is a big one. It's not insignificant. They have a long postoperative
Hmm.
course. They get swollen and so forth. They may have some loss of sensation, possibly. I don't know,
Yep.
and that takes time to recover. So, but there are many indications that you pointed out in your paper in the clinics of facial plastic surgery that I'm very interested in. So tell me, what kinds of situations would you recommend a lip lift other than just to volumize the lip? When
So,
would you say, okay, this is a good time to do it? And also, um, uh, when like for instance, after a nose job or
mhm.
rhinoplasty, you might uh, it may be indicated. Correct?
Correct. Yeah. Yeah. So, I mean, there are situations like that where you have either orthognathic surgery, meaning jaw surgery, or rhinoplasty, and that can change the laxity of the lip and the position of the upper lip where it sits for many reasons. That I've seen. I was doing a survey for a couple months, but I lost track of it, to see how many of the patients coming in for lip lifts had prior rhinoplasty and if they think it was caused by that. Orthognathic surgery, you certainly see caused that. The main indication, so I'd say the most clear indication that I see for many patients is just lack of tooth show. So they have poor incisive display, you don't see the teeth. And that's why I get a lot of referrals from dentists where instead of lengthening the teeth and making the face longer, they say, okay, let me treat the soft tissue component of this, get rid of the hooding of the curtain in front of the teeth, and then now I can keep the teeth looking delicate and appropriate for the rest of the face. The reason we like to have incisive display is that it portrays youth, it portrays sensuality, and I'd say an appropriate brightness to the face, and as well as an important skeletal soft tissue balance to the face. So we look at soft tissue and skeleton on the face, and teeth kind of are part of the skeletal appearance of the face. So you want someone balanced. You want to have some skeleton appearance, meaning you would have accented cheeks, noticeable teeth, those parts, and you don't want too much where they look skeletonized. So you need a nice balance between these soft tissues and the teeth itself. And in addition to that, you don't want to look at somebody and just see darkness. There are two areas on the face that you see brightness, and that's in the eyes and the teeth.
Yes. Yes.
So when it's covered, people tend to have the appearance of being senile, meaning being older. So they get
Okay.
the senile upper lip, the droopy upper lip. So the darkness is not sexy and it doesn't look young.
Okay. Does that apply to men and women?
Both, yes, yes.
It
For
does.
men especially, men
Yeah.
do get long hooded upper lips, and they lose their sexuality. And
Hmm.
men, don't look at that. But certainly, I do see a lot of men that I see, and they just look older because of this. And you end up doing a lip lift on them, and they look younger immediately, even when they're swollen. And it's
Wow.
not a sexy appearing lip when they're swollen, but they still look younger.
Wow. So you've done a number of men.
Yeah, yeah,
Hmm.
yeah, tons.
Oh, okay. Okay. I
Yeah, and
didn't.
they actually hide it better initially because the swelling for these kind of procedures can go up to 3 months.
Yeah.
And guys, after 2 weeks, they have some facial hair on it. You can't even tell.
Right. So, how do you tell the patient after this? Well, first of all, can you describe your surgery before we describe what it looks like afterwards?
Sure.
Can you tell me in simple terms, what do you do surgically?
Okay. So the type of lip lift, we call it a modified upper lip lift, which refers to a deep plane lip lift. If you were to try to classify it,
Is this called a Talei modified upper lip?
yeah, I haven't put my name on it, but
Oh, you have a
but
patent on this one, or?
no, I teach it to everybody. So it's
Okay, okay.
but the type of lip lift, the modified upper lip lift, refers to a deep plane release with a secure suspension, which means we follow the classic bull's horn incision, which means we make the incision at the junction of the lip and the nose. So you want to leave the units on the face separate. You never want to join two units, meaning you don't want to attach the cheek to the nose. You don't want to put the lip inside the nose. You don't want to do anything like that. The nose stays the nose, the lip stays the lip.
Mm-hmm.
In order to achieve that, you can't cross that boundary. You have to maintain the incision in the natural crease. I don't make a limited incision because limited incisions, meaning shorter ones, scar worse because there's more tension, there's more tethering, so they actually scar worse. The longer incision heals better within the natural crease, meaning I also don't extend it laterally where there's no crease if somebody doesn't have a crease. So you stop it wherever the crease stops. But that's the crease right there at the base of the nose. And we use that crease to design an excision, meaning an area that we cut out of upper lip skin. We remove excess skin that's going to be right here at the base of the nose, release everything in a deep plane, meaning under the SMAS and above the muscle between those two layers, which allows you to redistribute the skin evenly and without tension. And we secure the SMAS, which is that deeper layer under the skin, up to the piriform ligament, which is a series of dense ligaments above the periosteum, or the bone on the nose. And we just close it up like that, and people end up getting a lift out of it, which means they get a shorter upper lip. It sits in a higher position. Mm-hmm. It lifts the corners as well, revealing them, which is different than other lip lifts. It gives more tooth show, more accent, and more volume show, which means you're not increasing somebody's volume. You're not adding anything to their face, but you are increasing the vermilion show. So you're increasing their apparent volume, what you're actually seeing. So it's buried before the red part of the lip, and then it lifts up, so you're seeing the front wall of the lip now. So it does look like patients have more volume afterwards, even though you haven't added anything. Right. The healing for something like this, it's a 20-minute procedure. I tell people it's 45 minutes because it takes about 20 minutes to let them numb and then 20 minutes to do the procedure. They go home with stitches. We take out at day 3 and day 5. Typically at a week, they look gigantic. It looks like a huge upper lip, which is very different than other lip lifts. Other lip lifts, where you're not really doing much work internally, they heal very fast. However, it doesn't last very long. It's not a big lift. You can cause scarring on a large majority of patients and effacement of the nasal base, widening, loss of structure. So a lot of bad things can happen, but they do have a fast recovery. In those cases, I think fast recoveries don't benefit you because you've just screwed someone for life. So who cares if you healed in a week? The rest of your life, you're going to have a bad outcome.
Right.
So I do see a big benefit in doing this kind of lip lift, regardless of the sacrifice that we take for the recovery time. And the recovery time itself does go up to 3 months, which in my mind does benefit the healing of the scar because the swelling limits the motion on the upper lip, and having that decreased dynamic movement does help the incision heal better. So there is a benefit to it. But I tell patients at a week, you're going to look huge. At 2 weeks, you look less huge. At 3 weeks, you're going to look what we call passable, which means you can go out in public and 9 out of 10 people won't realize you did anything. 1 out of 10 is going to be your friend, and they will realize you did something because it looks off. At 2 months, you're looking pretty good, and you just have swelling left up here in the upper lip. Usually on one side, you have a bump. That's just muscular induration or muscle thickness. By 3 months, you look perfect. You're only about 20% healed, but you're perfect looking. And the healing for any kind of paper cut, usually at a year, is 80% healed. At 3 years is 95% healed. So that applies to a lip lift or facelift or anything like that as well.
Mm-hmm. And how do the women camouflage? Because I've seen those pictures as post-operative pictures, and the lip looks horrifying, to be honest with you. And I have to say, you have a lot of guts, because when I looked at that, I'd say, wow, what did I do here? The lip looks so big, and it's scary, And yet, as it settles, I have to tell the audience that you've gotten some magnificent, beautiful results that I haven't seen any other plastic surgeons achieve. So that's why I'm obviously speaking to you, because I know you're an expert at this in this specialty. But what do you tell, how do these people camouflage that? How do they walk around?
Well,
You got 3 weeks,
mhm.
at least 3 weeks of downtime, would you say,
Yes. Yeah.
initially? So
3 weeks
they
major
have to be
downtime.
prepared to take off 3 weeks and not really be encountering a lot of people that they know.
Correct. Yeah. And they all do, and they all prepare for it appropriately. So the three
Okay.
weeks doesn't seem to be a problem. They just time it appropriately.
Yeah.
It's that second 2 months that's kind of rough for them to get through. I prepare them repeatedly during the consultation, just telling them, listen, nothing else matters. Do you understand what I'm saying? Like, yes. I go, your outcome will be perfect. You're going to look great. It's going to be balanced. You never have to think about that. Nothing is going to go wrong. The chance of something go wrong is almost zero. Okay.
Okay.
But you have to be prepared for the 3 months. Do you understand? Yes. I go, it's 3 months. Do you understand? Yes. So I tell them repeatedly, and they get it beforehand and they time it appropriately. It doesn't mean they don't get nervous. So I have my own kind of follow-up that I do that involves the proper amount of handholding. So
Okay.
I see patients 3 days, 5 days, take out the stitches. I see them at the 1 month mark.
Okay.
Usually I see them at that point. So I see them once a month for about 3 months, 4 months. And if you see them more frequently than that, they might think something's wrong. If you see them less frequently, they're wandering about way too long without somebody reassuring them that everything's fine. So once a month seems appropriate.
Uh-huh.
At the 1 month mark, I use that opportunity to inject them with 5-FU. So I take 5-fluorouracil and I inject it deep into the muscle to speed up the swelling a little bit.
Yeah.
Not superficially and not Kenalog, because Kenalog it's an area, again, just like Juvederm has 2 areas of sensitivity, Kenalog has 2 areas on the face that are hypersensitive. 3 areas: forehead, under eye, and lip. So those are 3 areas that Kenalog is very reactive, meaning it can cause a lot of atrophy and discoloration. So I just use 5-FU on that 1 month visit. The
Very
2
good.
month visit I use to either inject again or to laser the incision with a CO2 laser. The 3 month I give them the blessing and I say, okay, you're good to go. So I take a photo at that point and it looks awesome. 4 month I see them again just in case they need to have another laser done.
Do you ever use a pulse dye laser?
I don't
any,
use it much on that
uh-huh.
because the redness will end up going away by on its own pretty quickly. I do use the pulse dye for bruising around the lip sometimes, but for the incision itself, it seems not to be necessary. The CO2 is really what helps blend the incision, which is barely visible in the worst case scenario when you do a lip lift like this.
Okay, excellent. You haven't talked about the lower lip now. What do you? So we don't have any lower lip approach other than
surgically.
Yeah.
We don't have lifting. We have volume augmentation. So
yeah.
On the lower lip, we use fillers or we use surgery. In the surgery, it is typically the 2 most common are called a VY plasty or a triple VY or a W plasty. And that's where we're making 3 VY incisions inside the lip to expose internal mucosa out. The contraindications for that are somebody who has a floppy upper lip already. It's going to make it floppier. So they have to have a pretty tight upper lip to do that.
Yeah.
The other is doing grafting into the lip. So I advise strongly against implantation with implants like silicone implants because alloderm is also causes a lot of problems. So silicone is great because you can take it out, but it feels horrible. So why use it? It's a stiff implant. Right. Alloderm is soft. However, alloderm has a tendency to contract. So it causes horizontal contracture and it changes the smile. And once that happens, you can't fix it. It's very difficult. The more benign appears to, and this is not without risk, but the more benign appears to be either SMAS grafting or dermis fat grafting, meaning you can take the SMAS from the upper lip or you can take the SMAS from doing a facelift and you take that layer and implant it. It seems pretty benign, innocuous. And the other is to do a dermis fat graft where you would take a graft from usually the bikini line, the size of the lip. You peel off the epidermis and you implant the dermis with a little bit of fat on the back of it. So those seem to be benign. I haven't had any issues with them. However, the same exact thing can happen, which is contracture. So it's more common with alloderm and with Gore-Tex, but it can happen as well with dermis fat grafting. It's just a much lower incidence.
Do you have any trouble after surgery with the smile? Is the incisions in any way accentuated by when the patient smiles after you do a lip lift?
No. So the only time you'd ever worry about seeing the incision, which I wouldn't call it a worry, but the only time you can actually see it, and I tell patients this, I say the incision will be barely visible. meaning it's not invisible, but nobody in real life would ever be able to see it. The only case that they will be able to see it is if you stretch it out for them and point it out to them. So you'd have to stretch it and point it out to them, and at that point you can see the incision. Otherwise, it is
that's
not
true in
visible.
any incisions on the face. Of course, you know you always see a telltale sign, and well, I think we've actually covered 99% of what I want to talk to you about.
Wonderful.
And I really appreciate your time and your willingness to talk to me. And it's always a pleasure to have Dr. Talei, to listen to him and to learn from him. And I'm a big fan. And I thank you for being with me today. And it's been a pleasure.
It's always great seeing you, Dr. Kopelman.
Okay, great.